Hello, everybody. Today we're going to talk about pharmacodynamics. And just a reminder, remember, pharmacodynamics, it is going to be talking about what the drug is going to do to the body. So we are going to go through this lecture. Just remember to keep scrolling through each slide and then hitting the play button so you can hear the lecture. When we are administering medications to the patients, remember there's an intent behind that drug administration. We have a reason. Maybe it's the patient has a medical diagnosis and we're treating a condition, or maybe they have a symptom and we're treating that symptom. Therefore, when we administer the medication, there is going to be an intended therapeutic effect that we are expecting to see. So when we are giving that medication, it should be causing what's called a primary response. When it comes to the medication going throughout the body, it is going to then cling to different receptor sites in order to cause a physiological reaction. Sometimes, though, it doesn't just cling to the intended receptor site only. So now we have other receptor sites that are being triggered, and we could then end up with secondary effects. Sometimes these are also desirable, but most of the time it's just the primary effect that we are desiring. So just remember, it could be desirable or undesirable. On this slide, we're going to talk about adverse drug reactions. And this is going to be defined by the World Health Organization as any noxious or unintended and undesired effect that occurs at normal drug doses. Now, if by chance the patient accidentally took too much, or maybe they intentionally took too much of the drug dose, and remember, then we'd probably more so expect to see an adverse problem in that case. When we're talking about the adverse drug reaction, we're just talking about unintended, and this is at the normal dose. And of course, it can range anywhere from being just an annoyance, or it could be very serious where the adverse drug reaction is now life-threatening. Adverse drug reactions can include side effects, can include toxicity, allergic reactions, idiosyncratic effects, physical dependence, carcinogenic effects, or teratogenic effects. So let's discuss a little bit more about each of these on the next slides. I don't know if you had a chance to look up in the drug guide different medications, but I really encourage you to look through Nursing Central, get familiar with Nursing Central. I suggest just choosing whatever medication you're thinking of and look it up. Maybe look up several different medications. Almost every medication has a side effect of some sort. Very rare that we wouldn't have any side effects. Some medications have multiple side effects, and if you look at the drug guide, it says a whole big long list of different side effects that now you as the nurse, you're going to have to look for in your patient. And of course, in the drug guide, it does tell you the difference between which is a more serious side effect, and it is going to be in capital letters, and that's going to indicate it's life-threatening. The ones that are underlined mean that those are the more common side effects that we see in the patients. And then, of course, the rest are just side effects that were determined throughout the clinical trials. The side effects can be predictable secondary effects, and sometimes they're harmless, not going to cause any problems when the patient takes them, but then sometimes the side effects can then cause injury. Sometimes we will actually see a benefit from the side effect. And sometimes those side effects may outweigh the benefit. Maybe the patient is getting stomach pain from the medication. Maybe they're having nausea from the medication. Let's say, for instance, an antibiotic. The antibiotic is being used to treat an infection, but now the patient is experiencing nausea because of the antibiotic. Well, we know that the infection is serious and we need to treat the infection. Therefore, sometimes the side effect is going to outweigh the benefit. And of course, we have medications that we could use then to treat the nausea, which is then treating the nausea from another medication. So sometimes we'll add in another medication to treat the side effects. We were talking about side effects, and remember, sometimes this can be predicted, and we know that it is most likely going to happen with all the patients that take these medications. And of course, sometimes it's good, sometimes it's bad. I do have some examples listed here on this slide. Nitroglycerin is a medication that is used for somebody who has the diagnosis of angina, and when they are having periods of chest pain, they can take the nitroglycerin and they will use this sublingually. It works very quickly. And one thing that happens with the medication is the medication will cause vasodilation. And when that vasodilation happens, obviously we're trying to get more oxygen to the heart, but it also causes vasodilation elsewhere. And in this case, the vasodilation to the blood vessels leading to the brain dilate, causing more blood flow to the brain, thus causing a headache. This is not an allergic reaction. Again, it is just an expected effect that we know will happen most likely with our patients. Benadryl is another example of a medication that has an expected secondary effect. For most patients, it will cause drowsiness. And of course, sometimes this is good, sometimes this is bad. Why is somebody taking Benadryl? Well, usually it's for an allergic reaction. Maybe they have a rash, maybe they're itching from the rash, and of course the Benadryl will then help them with that rash, thus helping with the itching. Maybe the itching was causing them to not be able to sleep because they're just scratching, and that definitely could be beneficial to calm them down so they can go to sleep and get a good night's rest. Of course, if somebody has to go to work and they have to take the Benadryl, that might be a bad thing, especially if they have to drive, because we know it can cause the sedation. And of course, we want them to be safe. Benadryl can also be used for people when they're just having trouble sleeping, and it's just that secondary effect or that side effect that will help them to sleep. So sometimes you might hear people that use the Benadryl to help them sleep at night. And the nice thing about the Benadryl, it doesn't have the addictive factors as some of the other sedatives that we have. So it is relatively safe to use for people to help them with sleep, and then they aren't getting addicted to that medication. So these are just some examples of side effects that are expected side effects. When administering medications, we also have to think about adverse drug reactions. There is a potential that patients could end up with what's called a toxic effect, and this is where the medication accumulates in the blood at a level that is above therapeutic level. Why would this happen? Well, it could be that the dose is incorrect and it's too high. It could be that the frequency is incorrect and we are giving it too often, where the previous dose hasn't had enough time to clear out of the system. It could be a problem with the patient where maybe their liver isn't functioning well enough. And so metabolism in the ADME is affected, causing that buildup or backup of the medication and then leading to toxic levels. It could be that the kidneys aren't clearing the medication out of the body. So let's think a little bit about this. Let's think about insulin. If we would accidentally give too much insulin to the patient, what would an overdose of insulin do? Insulin is given to our insulin dependent diabetics. And remember, the intent is to lower blood glucose level, if you didn't know that. And of course, you could look this medication up in your drug guide. If we would overdose a patient on insulin, then of course, now it could lead to a decrease in the blood glucose level too low, where now we're causing hypoglycemia. And then, of course, hypoglycemia, it could actually kill our patients. So very serious if the patient would overdose on insulin. So now thinking about this, thinking about toxic effects, if you're the nurse, so as the nurse, what would you do if you are administering a medication that has a known toxic effect? So here's another example, Tylenol or acetaminophen. If you would look up acetaminophen in your drug guide, it has a known toxic effect to the liver. So if we have a known toxic effect, a specific body organ that could be affected, as the nurse, what are you going to do there? Well, in this example, the known toxic effect is the liver. Now, during your assessment, when you go and you reevaluate your patient after you have administered the acetaminophen, you should also be asking questions about the liver, because we know it could potentially be harmful to the liver. So now let's include that in our assessment. We can do now a focused assessment on that particular body organ, and that will help us to understand and recognize early whether or not there's a problem with that specific body organ where that known toxic effect could occur. Idiosyncratic reactions, these are very unpredictable, where a patient can overreact or underreact to a drug. Why is it unpredictable? Well, this is where during the clinical trials, obviously we cannot figure out what every person in the entire population of the world, how they are going to respond to the medication. And remember, it's just a sample of the population, and that's how we gather the side effects. So this would be a very unpredictable. Maybe that person has something else going on in their body leading to this idiosyncratic reaction. I had a patient one time who I had given Phenergan for nausea, and she was pregnant. She was vomiting excessively, and the doctor actually brought her in and wanted to give the Phenergan IV, and we put it in a full liter of IV fluid. So I started the IV, I started the medication going through that fluid, and it was probably about 10 or 15 minutes later where the patient's mom had come out to the nurse's station and got me. And she's like, "Can you come check on my daughter? You know, something weird is going on." And so I went into the room, and she's laying in the bed and she's looking at me. And next thing I know, her arm like jumps up in the air. And then her other arm jumps up in the air. And randomly her arm would jump or her leg would jump. And it was just these random reactions. And I realized right away, oh my goodness, well, the only thing different that we have done is we started this medication. So it must be the medication causing this problem. So what do you think I did first? The thing I did first was I stopped the IV, because you want to stop whatever is the potential problem. Let's not continue and give any more of that. So I stopped the IV, and I actually went out and I called the doctor right away and realized this was a adverse reaction occurring. And I was kind of surprised with what the next order was. I actually had to give Benadryl IV to kind of reverse that. And I thought that was interesting and it worked. And then she was okay. But now we realize, that was an odd reaction and she should probably never have that medication again. So it did then go on her allergy list. So that was just a very interesting situation that it has always stuck out in my mind because I had never ever seen that before and I probably never will see that again. This slide here goes over the clinical trials and how we come up with the standard dose for our patients with that particular medication and also the frequency of the medication. And of course, remember, sometimes it's unpredictable because, again, the clinical trials are going to go by whatever the average was in order to create the standard dose. So we do recognize sometimes, like the majority of people, they can tolerate the standard dose, but sometimes there's people where they are going to require a lower dose, or sometimes there's people that are going to require a higher dose. So of course, we need to recognize that there are sometimes outside the norm things that can happen, and we may then see a higher or lower dose with the medications with our patients. I'm sure you've heard of allergic reactions before. Well, an allergic reaction, this is going to be an immune response. The first time that we give a patient the medication, they will not have this allergic reaction, and it's because their body is going to build up antibodies against the drug. So it's not going to be until the second or the third time they have that same medication where we will then see them present with the symptom of the allergic reaction. And I do have a picture there on the slide. You can see the person before, and then you can see what happened to that person during their allergic reaction. So the allergic reaction, again, it's also determined primarily by the degree of sensitization of the immune system. It's not by the drug dosage. The patient's sensitivity to the drug, it can actually change over time where it can then get worse and worse and worse. And if we, like this patient here, I mean, look at her symptoms. Her whole face is swollen. And that's kind of scary, but because right there, her face is swollen very close to her airway. And maybe the next time if she would have this medication, it would then cause the immune response to her airway. And now that could lead to an anaphylactic reaction. Very serious, that could kill your patient. So be very, very careful. I mean, if a patient is allergic to a medication, we should not give that medication again. There are very few drugs, though, that cause severe allergic reactions. What's the most common? Well, the penicillins, which is an antibiotic, that's the most common drug that can cause severe allergic reactions. You may also see allergies that are induced by sulfonamides. Sometimes we see it in diuretics, other antibiotics, or in oral hypoglycemic medications. So always think to yourself, I'm giving my patient this medication. I should watch for allergic reactions. You might be thinking to yourself, well, what exactly am I going to be looking for in my patient if they were to have an allergic reaction? Well, some of the common allergic symptoms that will present will be hives, it could be a rash, it could be itching of the skin, it could be swelling or clear drainage coming from that nasal passage. It could also be wheezing, which of course then is constriction of the smooth muscle surrounding the bronchioles. So make sure that you are going back to see your patients after you administer medications and not only looking for that therapeutic effect, but also checking to see if there's any negative side effects that are occurring, such as the allergic reaction. When administering medications to your patients, you do need to recognize some other terms. Carcinogenic, this means that some medications, the environment, and other chemicals could have the potential to cause cancer. So do recognize some medications could actually lead to cancer. Another term is teratogenic, and this means that a medication or a drug can induce birth defects. In your drug guide, they used to have listed specifically on the medications the pregnancy category or the pregnancy class, and this would then tell us the ability of the medication to cause harm to the fetus. Now, if you go to the drug guide, it's kind of hard to find in the drug guide as far as what the class of the drug is. If you want to look up in the drug guide, thalidomide, 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 this is actually a pregnancy category X. And if you scroll down to the contraindications or precautions, it says right there under contraindicated in, and then it says OB, and it states it may cause fetal harm. You can also look up in your drug guide teratogen, Teratogen. And if you look up in the Tabor's Medical Dictionary, which is the green box with the T in the center, it will talk about the different pregnancy categories, and it does have a table listed there. It talks about pregnancy category A, B, C, and D, and X. I just suggest kind of reviewing that table, kind of getting familiar with the differences between A, B, C, D, and X. So please do that. Please look that up in the drug guide. When administering medications, remember, we're talking about pharmacodynamics right now. And remember, this is what the drug does to the body. There are what's called drug interactions that can occur. It may be drug to drug interactions. Remember, lots of patients are on several medications. They're not just taking one medication at a time. And I can tell you a lot of the patients you're going to care for, they have an extensive medication list. So just remember, drugs are chemicals and they can react with one another, leading to complications. We also need to think about drug to food interactions. Remember, food also can have chemicals in it. Sometimes it's the chemicals that can interact with the medication, or it may just be where it's affecting the absorption rate of the medication. Maybe if there's food in the stomach, then the medication isn't going to absorb adequately. And then there's also drug to laboratory interactions that we have to think about. And we're going to go over these on the next few slides. Let's talk a little bit more about drug to drug interactions. And of course, what can happen in this? Well, we can see an altered therapeutic effect of a drug due to the interaction with another drug. What specifically could happen? Well, one drug may intensify the effect of another drug. One drug may reduce the effects of another drug, or it could be a combination of the two drugs. And now we're seeing a chemical change, and now it's producing a completely new response that we haven't predicted. We are going to talk a little bit more about this. There are 4 categories of drug interactions. It could be direct chemical or physical interactions. It could be pharmacokinetic interactions. So now you got to think about what we've learned in past classes about the pharmacokinetic aspect of medication administration. It could also be pharmacodynamic interactions, such as effects on the onset, the peak, the duration of action, or it could be a combined toxicity. So we are going to talk more about each of these 4 categories now on the next several slides. chemical or physical interaction, this is going to be where the drugs interact due to their chemical or physical properties, like I've already mentioned. Usually what will happen is both the drugs are inactivated, but now they're not going to cause that therapeutic effect that we have intended with giving the medication. Oftentimes you will hear this called a drug incompatibility. If you look up in your drug guide, in past classes, we had you look up ibuprofen, ibuprofen. If you want to look up ibuprofen, this is an over-the-counter NSAID. And if you look that up and you scroll down to interactions, there are several drug-to-drug interactions listed in your drug guide. I just wanted to kind of get you headed towards Nursing Central. Use your resources, get to know your resources a little bit, so that will help you when you go to the clinical setting. A little bit more about the chemical or physical reaction that occurs among two or more drugs. Most commonly, this will occur in an IV container or tubing. Remember in fundamentals when you were drawing up medications in the lab and you're talking about giving medications IV, sometimes we can have drug to drug incompatibility right in that IV tubing. A lot of times it will crystallize in the IV tubing if we shouldn't give those two drugs together. And we should never do that. We shouldn't ever give incompatible drugs through the same IV because those crystals aren't good. They could actually get into the bloodstream and it could act like a blood clot going through the patient's bloodstream. No good, right? That could kill our patient. Also, you were taught never to administer an IV drug that is discolored or cloudy because at some point now a chemical or physical reaction has occurred. So we definitely don't want to use those medications. Let's talk a little bit about the pharmacokinetic interactions. And when it comes to the drug-to-drug interactions, it could be affecting all four of ADME. First, we'll talk about absorption. So drug-to-drug interaction, it could affect the rate of the absorption of one or both the drugs can change. For example, one drug could block, decrease, or increase the rate of absorption of the other drug. So therefore, one drug is being blocked, the other drug is going to then be absorbed much faster than it's intended. So it is messing things up with those medications. Some more pharmacokinetic interactions altering absorption. It could be where the drug to drug interaction causes an elevated in the gastric pH level. And remember, some medications, they will want to ionize in a more alkaline environment. And if we're increasing gastric pH levels, now it could affect that absorption rate. Laxatives could cause an alteration in absorption. Remember, we gave this as an example also, where if somebody is taking laxatives, now if they are taking another medication, the laxatives are going to speed up and they're going to be having bowel movements, and most likely they're going to end up having diarrhea if they've taken too much. But now we got to think about, what about that other medication? If the GI tract is really moving along, well, now the other medication might not get absorbed. It might just pass right on out of the body. There are some drugs that decrease peristalsis. They slow things down, and now the drug sits too long in the GI tract, and now more of what is intended is actually absorbed along that GI tract. Some medications will induce vomiting, and if somebody is vomiting out, well, now how are we going to put a pill in? They are going to be losing that fluid abnormally, and of course they could be losing now the medications abnormally. There are some drugs that are absorbent drugs, causing quicker absorption of those drugs. And then there are some drugs that are going to decreased regional blood flow. And remember, we talked about how the blood flow needs to be adequate at the tissue in order for the drug to exit out of the GI tract and to get to systemic circulation and then exit out at whatever body tissue that is being affected. And if we have decreased blood flow, it's going to alter the amount of the drug that is useful in the body. A little bit more about increased or decreased gastric emptying time. If a drug stays in the stomach or the small intestines longer, think about the absorption rate. More amount of the drug is going to actually be absorbed. Drugs that speed up gastric emptying, such as a laxative, is this going to increase or decrease gastric and intestinal motility? Well, remember, it's going to increase. It's going to cause increased peristalsis. It's going to move things through the GI tract quicker. And then what's going to happen to the drug? Is it going to increase or decrease absorption of the medication? Well, it's actually going to decrease absorption of the medication, and it could cause where none of the medication's being absorbed. So we do need to pay attention to these things, especially if maybe it's not a patient taking a laxative. Maybe they just have a symptom of diarrhea. Well, remember, we got to think about those patients having that symptom that, okay, if they have to take other medications, now those other medications may not be absorbed. Or if they're vomiting, that's abnormal. That's increased gastric emptying, but now it's coming out through their mouth. And again, we got to think about, hey, maybe we need to find an alternate route for their other medications just to guarantee those medications are getting into the body. Another drug-to-drug interaction to be aware of is narcotics or opioids. They actually slow down the GI system and can actually lead to constipation in those patients. So now we think about the GI tract is slowing down. This is going to increase or decrease absorption of other medications. Well, it can actually increase absorption of other medications if that medication is now sitting longer in the GI tract. I need you to think back to the first day of class when we talked about gastric pH levels and ionization of different medications. So when gastric pH is decreased, a weak acid drug such as aspirin is going to be absorbed much faster. And remember, drugs that increase the pH of gastric juices can decrease absorption of those weak acid drugs. So here's an example. Antacids, such as Maalox and Amphogel, are they going to raise or lower the gastric pH level? Well, they are going to raise the level of the gastric pH level. And therefore, if we would then give aspirin to these patients, that pH level in the stomach is going to be raised. And now we're going to have ionization of the aspirin right there in the stomach. And remember, now they're polarized, they have that electrical charge. Now they're not going to be able to cross over the cellular membrane, and therefore we're not going to have absorption of the medication. The aspirin's not going to work like we're intending it to work. Tetracycline is an antibiotic that I mentioned in past classes, and I use this as an example for some drugs can react chemically to other drugs. So in this case, tetracycline, if it is given with antacids, it will actually form a complex and then it won't be absorbed. Tetracycline is an interesting medication because it also will form complexes with dairy products. And of course, this is a drug to food interaction, but I wanted to make you aware, here's a medication that not only do we have drug to drug interactions, but we also can have drug to food interactions. So if the patient gets prescribed this medication and they go and they pick up their medication at the pharmacy, it will come with a label right on that bottle just to remind them not to be taking antacids or any milk products, any dairy products with that medication. Now let's talk about the D part of ADME when it comes to drug interactions. And I've already mentioned this also previously when we talked about protein bounding drugs. So when two drugs are given together that are highly bound to protein or that albumin in the blood, they are then going to compete for those albumin sites. And then one drug is going to take all those albumin spots. It is then going to leave the other highly protein bound drug that has more free floating drug that is available to be used by the body. Well, now more is going to get distributed of that one drug, and that could potentially lead to drug toxicity. So I already mentioned in past classes, we shouldn't really be giving two highly protein bound drugs together just because we recognize it can cause a situation like this. You might think to yourself, well, what happens if my patient needs the medications that are both highly protein bound drugs? What in the world can we do now? Well, when two highly protein bound drugs do need to be given together, we need to recognize that the doses may need to be decreased. And of course, this is going to be the physician that is going to need to order it this way. So I do have some examples of highly protein bound drugs. Coumadin and NSAIDs, such as the ibuprofen, like we've already talked about, or another combination could be furosemide, and the trade name is Lasix, combined with ibuprofen. And of course, remember, you have the drug guide. You can look this information up and you can see right in the drug guide what is the percentage of protein binding for each of these specific drugs. Drug-to-drug interactions can also affect the M part in ADME, the metabolism or biotransformation. So certain drugs can stimulate liver enzymes, and these would be called enzyme inducers. So the drug then stimulates the synthesis of the CYP enzymes, and then that would be an inducer. So now what happens? Well, the enzyme inducers will actually increase metabolic rate of other drugs. So those other drugs are being metabolized, and if they are being metabolized faster, this will also then lead to more rapid drug excretion of that other drug. So now what's going to happen? Well, now it's going to cause a decrease in the drug concentration of the other drug in the blood, and maybe now it didn't have enough time to actually cause that therapeutic effect like we were intending. So just keep these things in mind when you are administering different medications. Here are some examples of hepatic enzyme inducers. Phenytoin or dilantin, this is an anticonvulsant. Phenobarbital is also an anticonvulsant and a sedative. Carbamazepine or Tegretol is also an anticonvulsant. We have an antibiotic listed there, rifampin. But then take notice if your patient is a chronic alcohol user. Well, remember, alcohol is actually a drug. It is a legal drug, and people can go purchase that on their own. Well, just recognize if somebody drinks alcohol all the time, and now we are giving them a prescribed medication, now that prescribed medication may actually be metabolized faster and excreted faster out of the body, thus reducing the therapeutic effect. Smoking cigarettes is also an enzyme inducer, that nicotine in the cigarettes. So we also have to recognize our patients that are smokers, they may also metabolize and excrete other medications much faster while they are smoking those cigarettes. And of course, we would then recognize and educate either if they're alcohol users or if they smoke cigarettes. If we really need to have this medication work effectively, we can educate them to limit their alcohol use while they're taking the medication and limit the smoking. We really try to encourage people to cessate with the smoking and just quit smoking altogether. There are some other drug to drug interactions where the drug is going to be an enzyme inhibitor. Well, drugs that inhibit the enzymes, those are the ones that are called inhibitors. So now thinking about this, inhibiting, what does that term mean? So an enzyme inhibitor, is that going to increase or decrease the metabolic rate of other drugs? Well, in this case, an inhibitor would actually decrease the rate of metabolism of those other drugs. So now what's going to happen to the plasma concentration? Well, the plasma concentration will then be increased, and now it could lead to toxicity with that other drug. So again, we need to recognize that this could happen. Some drugs can cause this. How is the E affected through drug to drug interactions in the ADME? So E stands for excretion. There are some drugs that could decrease cardiac output. Well, if we're decreasing cardiac output, this will actually decrease the blood flow to the kidneys. So think about this. If we're now slowing down the blood flow to the kidneys, is this going to increase or decrease drug excretion? Well, it's going to decrease drug excretion. So now what's going to happen? If it's not allowing, the kidneys aren't allowing the drug to be excreted out of the body, what's going to happen to this drug? Well, remember, it's now going to back up. It could build up. It could stay in the body longer than what was intended. And again, it could lead to toxicity. We talked about how some drugs can alter the pH level in the GI tract. Well, we can also see alterations in the urine pH level affecting drug excretion. So if we have a more alkaline urine, this is going to promote excretion of drugs that are weak acids, such as aspirin and barbiturates. So it's going to allow those drugs to go out of the body much faster than what is intended. So then now we could have a patient that has more acidic urine, and this will actually promote excretion of drugs that are the weak bases, such as amphetamine. So again, now we got to think about the urine pH, and we need to recognize this can also alter drug excretion out of the body. Drug to drug interactions could also lead to pharmacodynamic interactions, and it could be where combining two drugs together will have an additive or synergistic effect, or it could lead to an antagonistic effect. And we're going to talk about these on the next slides. Sometimes when combining two drugs, the sum of the effect of those two drugs can then lead to an additive effect. This effect can either be desirable or it may be undesirable, where we don't want those two drugs to be given together. An example of a desirable effect, if we give Tylenol with codeine, and I don't know if you've ever heard of Tylenol and codeine, and this can be combined where it's just one tablet that the patient has to take. Mixing those two medications together, they're both used for pain, but when we combine it together, two medications in one for the pain, we actually see very good pain relief using this medication. So if we're seeing good pain relief and that's what we're intending, that is a desirable effect. Apresilane, which is an antihypertensive, given with nitroglycerin, can actually cause an undesirable hypotensive effect. So now combining those two drugs together, it can then lead to hypotension in your patient. And of course, we don't want that to happen. Alcohol, when used with narcotics or opioids, both of those medications, they're both drugs. So alcohol is a drug, narcotics is a drug. Add those two together, they both can lead to CNS depression or central nervous system depression. So now giving them together can actually increase the central nervous system depression, and then that can definitely lead to a increased chance of decreased respirations with our patients. And of course, now we have a patient that is barely breathing. Not good, right? When you think back to oxygenation, this definitely would be an undesirable effect. We're talking about the antagonistic effect, which falls under the drug to drug pharmacodynamic interactions that we can see. The antagonistic effect, this is going to be a drug that will actually block a response. Sometimes when we give a patient two different medications and that combination, then it is going to have an opposite effect. Sometimes this is desirable and other times it is undesirable. So let's say we have a patient who needs to have a beta adrenergic stimulant such as isoprel. Well, we wouldn't want to then give them another medication such as Inderal, which is a beta adrenergic blocker. Can you see how one is a stimulant and one is a blocker? What will happen is they will actually cancel each other out, and then we're not going to have a therapeutic effect. That would be undesirable. Well, it may be a desirable effect. For example, let's say we have a patient who was taking narcotics or opioids and now they have overdosed. Now we have respiratory depression, and we know it is the opioid that is causing that respiratory depression. Well, now we have a complication. This is serious. Our patient might die on us. We need to clear that medication out of their body. Therefore, we do have basically it's an antidote, and it is called Narcan. And what Narcan will do is it will bind to the opioid receptors, blocking the opioid from binding and turning on those receptor sites, which is then leading to the respiratory depression. So in the case of Narcan, then it is desirable because we're trying to save our patient's life here. So you can see how we do have some drugs they're going to block each other, and then other drugs it's going to be where it's beneficial when we are having this blockage. I like this slide because I'm a visual person. I really like to see things in pictures. It helps to connect the information. So we just talked about antagonist drugs and what they are going to do. And you can see that picture there on the right side of the slide. Antagonist drugs are going to bind to the receptor site, like I mentioned, and thus they're going to block the other drug from binding to that receptor site. Agonist drugs, then, that's what's in the middle there. Agonist drugs are going to be medications that bind to the receptor sites, and then they are going to turn the receptor on, and thus that is how we get the therapeutic effect. And then, of course, remember, that's also how we have side effects because other receptor sites are being turned on. So I just wanted to show you that slide. It's just a nice visual to kind of show you agonist drugs and antagonist drugs. We talked about how we have drug to drug interactions with prescribed medications. Well, I don't know if you've taken notice, but there's a lot more people that are taking herbs as far as using them for natural remedies. Well, we need to recognize as healthcare providers that the prescribed or conventional drugs that we are giving to our patients could potentially interact with those herbal preparations. As far as gathering reliable information on drug to herb interactions, it is lacking. You're not going to find the herbs in Nursing Central. You're not going to be able to look up that information. And thus, it kind of makes it difficult as a healthcare provider to actually then figure out, well, if they're taking these herbs, are they going to then interact with these prescribed medications? One example of a known interaction that we already know about, I did put there on the slide. So here's an example. St. John's wort, it does induce drug metabolizing enzymes, and it also reduces blood levels of many drugs. So pay attention to that. We are going to gather data on our patients as far as what medications they take at home. And remember, we have to include any herbal remedies that they are also using, just because we know it could cause an interaction with the prescribed medications that we are giving to the patient. We talked about drug to drug interactions. Now let's talk about how there could be interactions between drugs and foods that your patient is ingesting. So, what exactly could the food do to some of these drugs? Well, it could increase, it could decrease, or it could delay drug absorption. Remember, this is going to also be listed in the drug guide. We will see in the drug guide when we look up a particular medication, you're going to see drug to drug interactions, and you're also going to see, is there any drug to food interactions? Sometimes the food can bind with drugs, causing less or slower absorption. And remember, I already gave the example of tetracycline, and here I just gave it again. It does bind with food, especially those dairy products. So then what do we do? Well, we're going to educate our patient not to ingest dairy products while they are taking this medication. And does this mean they can't have any dairy products the whole time? No, it doesn't mean that. It just means that usually an hour before they are going to take their medication, and then 2 hours after they take the medication, they should avoid ingesting any dairy products. There are some other examples listed there. There are some drugs that have increased drug absorption with food. So now they're absorbing faster. So now it could cause more of the drug to be available in the blood than what was intended. So for instance, low pressor or macrobid. So therefore we would not want them to eat any medication or eat any food. Sorry about that. Eat any food while they are taking the medication. And again, it's usually 1 hour. They'll take their medication and then they're going to wait at least an hour or two after they take the medication in order to ingest food. So there are some differing rules depending on whether or not there is drug to food interaction. So we do have to pay attention to that. Make sure your patient is eating when they should be eating, if there are any of those drug to food interactions. And then, of course, eating the foods that aren't going to interact with the medication. A little bit more about drug to food interactions. This one's very serious. So MAO inhibitors, and this is going to be used for depression. We don't use these too often, but it is a class of medications that we will use for that. So MAO-I inhibitors should not be taken with tyramine-rich foods. Well, what in the world does this mean? Have you ever heard of tyramine being in foods? Well, foods such as cheese, wine, organ meats, beer, yogurt, sour cream, bananas, they are all rich in tyramine. Now, what in the world would happen if they ingest these foods along with the medication? Well, what will happen physiologically is more norepinephrine is going to then be released, and it can actually result in a hypertensive crisis. This is very, very serious. It's critical. It can actually kill your patient. So therefore, we definitely need to make sure our patient understands what foods they can ingest while they are taking this medication. And they are going to also need to avoid these foods for 2 weeks following stopping taking this medication. So maybe they're no longer going to be taking the medication. Well, even 2 weeks after they stop the medication, they still need to avoid these foods. Very, very serious. Here's another example. Theophylline cannot be taken with caffeine. It will actually intense the effect of caffeine. They're both stimulants. So what will happen is it will produce an exaggerated central nervous system excitation. Again, it could kill the patient. So again, be very careful when it comes to foods and drugs too. There are certain medications where grapefruit juice should be avoided. I don't know about you, but I don't really care for grapefruit juice. I think it's very bitter. I remember my mom used to like to eat grapefruit, and ugh, I didn't think that it was very good. So I don't particularly care for it. So you certainly wouldn't have to worry about this with me if I was your patient and I had to take a medication that um, was affected through grapefruit juice. So, what can happen? Well, grapefruit juice can inhibit metabolism of certain drugs. And again, your drug guide is going to tell you this. It's going to be listed under a drug to food interaction. I have an example here. In one study, co-administration of grapefruit juice produced a 406% increase in the blood levels of Plendil, which is a calcium channel blocker. That's pretty serious. Do you think toxicity might occur if we would give grapefruit juice with that medication? Yeah, probably so. That's not a good thing. So, the more grapefruit juice a patient would ingest, the greater the inhibition would be. So, inhibition can also persist for up to 3 days after the last glass of grapefruit juice. So, again, just pay attention to the foods, pay attention to those specific drugs that interact with specific foods. We want to avoid those foods if it's necessary. There are some medications that have what's called a drug to laboratory interaction. In past classes, you probably have learned about the different lab tests that we will do on our patients and then the different results of those lab tests, what is normal, what's abnormal with those results. You've also in past classes learned about electrolytes that are used by our body, and we need to pay attention to these with specific drugs. And again, it's going to be listed in the drug guide as far as which drugs have that drug to laboratory interaction. So, abnormal plasma or serum electrolyte concentrations can affect certain drugs. For example, a patient with decreased serum potassium levels or increase in serum calcium level will be more prone to digoxin toxicity if the doctor has prescribed them digoxin. So frequently, patients on digoxin will also be taking a potassium wasting drug. So just make sure that we're paying attention to our patients, paying attention to their labs also if we know that there's a drug to lab interaction. Now, what is your job going to be as the nurse? Remember all the things you've learned in past classes as far as medication administration. Make sure that you do understand the pharmacodynamics of things. And when you're administering the medications, remember, we don't just pass pills and then walk away from our patients and it just forget about what we're doing. You know, there's a thought process that goes behind medication administration. And you, as the nurse, you're responsible for making sure the medication is actually working and causing the therapeutic effect. So we're resolving the patient's problem, but you're also at the same time watching for any of those interactions. Because remember, all drugs are going to have some sort of side effects. And we need to make sure our patient is staying safe. We have to think about that aspect of nursing too. So, safety, quality care, it all goes into play with medication administration. Just make sure you're going back and re-evaluating your patient after you have administered the medication, looking for the therapeutic effect and then also looking for any side effects that might have happened. pay attention to those drug to drug interactions. Make sure you're not giving the drugs together. If there are going to be interactions, make sure that you're paying attention to IV medications. Make sure drugs are compatible to go through that tubing. Make sure you're not giving any outdated medications, any medications that are cloudy. When it's a liquid, like an IV vial, it should be clear for the most part. Pay attention to those different things. And then again, pay attention to allergic reactions, different things like that when you're administering it. You have a big responsibility here. As the nurse, how are you going to determine and identify whether an adverse drug reaction is occurring? I just have a few questions here to help guide you to determine whether that is what is happening. So your patient, you gave the medication, you go back in to check on your patient, you're checking them for therapeutic effect, and then you're also looking for any adverse reactions. Let's say now your patient's having new symptoms. So think to yourself, well, did the symptoms appear shortly after the drug was first used? If you see these symptoms, you're probably going to stop giving that medication. You'll collaborate with the physician on that. And then if you do stop the medication, now did the symptoms stop when the drug was discontinued? The doctor might want to verify it was the drug, so then they might reinstitute the medication. And now, did the symptoms reappear when the drug was reinstituted? That will kind of guide you that, yeah, it's probably the drug that's causing this adverse reaction. And then think about your patient. Maybe their illness itself could um, it could be causing the symptoms that they're experiencing. So we need to think about, is the illness itself sufficient to explain the event? Also, your patient is probably on other medications. So are there any other drugs in the regimen that's sufficient to explain the event? So this is kind of going to clue you in, help you to practice safe medication administration. We always need to think about our patient's safety, and therefore we do recognize that adverse drug reactions can occur. So let's try to be proactive and prevent it from occurring. So let's compare first, what is the prescriber's job and then what's the nursing responsibility? So the prescriber's job is to select the least harmful drug, and then of course they need to balance the potential risk versus the probable benefit. There may be situations where the patient, we know that the adverse reaction is going to occur, but maybe it's critical that they have that medication. And then maybe we can treat the adverse effect from the drug with another medication treating that adverse symptom. So now, as the nurse, then what's your job? Well, your job is going to be the one at the bedside. You are the one hands on. You're checking on the patient frequently. So you are the one who's going to be evaluating the patient for an adverse drug reaction. Therefore, it's up to you to recognize there's a problem occurring. The physicians, they come and go. They are not with the patients 24 hours a day. It is the nurse that's with the patient 24 hours a day. And of course, I'm talking inpatient hospitals. Another job that you have is to educate the patient and also the family members on how to minimize any harm. So what can we tell the patients and tell the families? Well, we can tell them to watch for any signs and symptoms that an adverse drug reaction may be developing. And then, of course, they need to notify the healthcare provider right away so the healthcare provider can determine, is it in fact an adverse drug reaction? The other thing we need to make sure we're thinking about is the patient taking any other medications that could interact with this medication, or are they eating any foods that could affect the drug? So keep these things in mind. This is going to help you prevent adverse drug reactions. Some other things that you can do as the nurse to minimize those adverse drug reactions. Well, you can, again, be proactive and anticipate any adverse drug reactions, and that can really help minimize the potential occurrence of those adverse drug reactions. So now, as the nurse, if we are giving a medication that has known problems for a specific organ in the body, we need to evaluate the function of any of those at-risk organs. So, for example, I have these listed here for you. Let's say there's a potential risk to the liver when we give this medication. So, what are we going to assess for? Well, it could lead to jaundice. We might need to use some lab work to monitor that liver. So, what lab work could we use? Well, we could monitor liver function tests. The kidney, there are some medications that are harsh to the kidney. So, how can we make sure that kidney is okay and it's not causing harm to the kidney? Well, we could do a routine urinalysis, we could do serum creatinine clearance on the patients, and again, they're lab tests. Anytime we have a lab test, remember the doctor has to order that lab test. So, what's our responsibility? It's our responsibility to make sure the order actually gets sent to the lab, make sure that the lab is actually performing the test. There's potential that some medications could be harmful to bone marrow. So, what could we do for that? Well, we could do periodic blood cell counts. So, you can see how we're going to focus in on those organs that could be affected, perform those tests, make sure we're monitoring them closely. So, here's another example. So, what organ would you be watching closely when administering Tylenol or acetaminophen? And remember, I talked about this previously. Remember, it can lead to liver toxicity. So therefore, we're going to monitor that liver. Just another reminder, anytime you have a patient that has a chronic disorder, those people, that particular type of patient population, they are going to be especially vulnerable to adverse drug reactions. So anytime you have a patient that does already have a chronic disorder, we have to monitor those specific patients a lot more closer than a healthy patient. Here's an NCLEX question that you can practice with. The question is, the following basic guidelines can help ensure correct drug administration. Select all that apply. I will let you think about that question and I'll let you look up the answer, see if you can find the answer. In past classes, most of you have learned about patient safety. I did post a video that I encourage you to watch under the week 2 module in Blackboard. And I just wanted you to review that just because it is a mom who shares her story of the result of a lot of problems that happen in the care of her son, where a lot of things were overlooked and ignored, and the ultimate result was her son's death. And we do know that medication errors are a major cause of morbidity and mortality with patients. There are 2 documented landmark reports from the Institute of Medicine. In 1999, it's called To Err is Human, and then in 2013, the Journal of Patient Safety. In past classes, you learned about national hospital patient safety goals, and there are goals that relate back to medication administration. And part of those goals are making sure that us nurses are doing our job adequately, and how can we ensure that we're not causing a medication error. More things that we have to do, more steps to medication administration. We now have to verify our patient's name and date of birth, and this really goes along with helping to prevent those medication errors. How big of a problem is it in our country? Well, it is estimated that medication errors occur and cause about 98,000 patients problems. There is an estimated, more so that the number is higher than that. They're estimating medication errors occur more likely 210,000 to 440,000 times per year. Those are staggering numbers. This means the patient has come to the hospital, and remember, we're trying to get them back towards wellness for the most part with the majority of our patients, but now we are causing complications for our patients. What exactly is a medication error? Well, I do have a definition provided here for you. The key note to take away from this is it is a preventable event. Therefore, we need to learn about this. We need to put forth the effort to maintain patient safety. We do not want to cause our patients any harm whatsoever. I'm not going to read down through this. You can read that definition on your own. In the hospital setting, the risk for medication errors is actually increased. Why so? Well, because in hospitals, each medication order, it actually gets processed by several people. The physician is going to be the one that orders the medication, and then we are going to be sending that to the pharmacy. Nowadays, with the computerized documentation system, the doctor can just put the order right in the computer and it will automatically be sent to the pharmacist. Well, now we have a pharmacist. That's our second person, a member of the team that is now handling this medication. And then it is going to go to the nurse. And remember, you are the last person in this whole sequence of events when it comes to medication. Therefore, you as the nurse, remember, you're the last line of defense in order to pick up on any of these errors and put a stop to it before we actually administer it to our patient and then cause them harm. So again, it's heavy responsibility that's being placed on the nurse now to ensure patient safety. So just be very careful. Make sure you're very vigilant when it comes to medication administration. Get the thought out of your head that you're just passing pills. That's not your job. You as the nurse, you need to think, and you really need to think at a higher level. We need you to problem solve and catch these potential mistakes just so we're not causing harm. I want you to think about the 6 rights of patient administration and think about why you, as the nurse, have to go through all those checks in order to ensure patient safety. Remember, those checks are there for a reason, and we are trying to prevent any problems. So when you're administering medication, make sure you are following all 6 of those rights of medication administration. Why so? I mean, look here. When somebody dies from a medication error, what is the problem? What's occurring? Well, 36.4% of the time it's an overdose. So now we have given too much of that drug. It has led to toxicity. Now it has killed the patient. 16.2% of the time it is the wrong drug. 9.5% of the time, it's the wrong route. Can you see how these correlate back to the 6 rights of medication administration? Some more causes of medication errors, and you can see here 90% of those errors, they are going to be due to these three things. So human factors, it could be a communication mistake or a name confusion. So again, remembering, go through those 6 rights of medication administration, making sure we're checking our patient's name, date of birth, making sure when we draw up the medications, we're getting the right medication. Make sure we're going through all those checkpoints to ensure patient safety. What can you do to help reduce medication errors? Well, there are some things that you can do. If a mistake happens, It is not going to do anybody any good if we just blame other people for this. Not going to help the situation. If an error does occur, it'd be better to figure out what went wrong in the occurrence. So then we can then put forth efforts to fix that problem. So don't name blame and say, oh my, Susie Q over there, look what happened, and start talking about it. It's not going to help the situation. There are some proven methods to help reduce medication errors, such as replacing the handwritten medication orders with computerized order entry system. I think really anymore across the United States, the only time you might see a handwritten medication order would be through a nursing home. Most hospitals, most outpatient facilities, they do now have computerized documentation system. Therefore, they have computerized medication administration. We not only have the Pyxis machines, but we also have those handheld devices, which allows us to scan the patient's ID bracelet. This really does help to reduce medication errors. So again, use that barcode system like I just mentioned. Do not use any error-prone abbreviations. We've talked about this in the past where we shouldn't be using text abbreviations. We also shouldn't be making up our own abbreviations. Only use approved medications when we are documenting. And then, like I said, if a problem does occur, we really should track those errors in order to make improvements. I know several facilities that I worked at, they would have a little box somewhere on the unit that was a locked box, and it had a slit at the top or a slot where if an error occurred, we could anonymously submit that the error did occur. Maybe we caught ourselves at the last minute. So a near miss is what we would refer to that. So a near miss. So let's talk about these near misses so we can make improvements, make sure it doesn't happen. I can tell you if a mistake does happen, another way we're going to track it is through an incident report. If we made an error, you need to call the doctor, notify the doctor of the error, and then we also need to complete an incident report. And that's just a way to track it and make sure that we are following through just to help prevent medication errors. Also, it also puts forth kind of a responsibility that we are taking care of our patients safely. Another thing we should do is involve the patients and involve the family members in medication administration. Make sure they understand what the medication is for. Make sure that they are also taking the medication as ordered, as prescribed by the doctor. Remember, these patients, they're going to be sent home, they're going to be discharged home from the hospital. We also want them to be taking their medication safely at home. So involve them in the care, educate them on signs and symptoms of adverse reactions. It's going to help reduce those medication errors. This is an example of a medication label that is found on non-prescriptions, and this would be over-the-counter medications. The FDA does require that medication labels are put on the packaging of these over-the-counter medications to give additional information to the patients as far as some warning signs, directions for use, making sure that they're taking the correct dose, making sure they're taking it at adequate times, not taking it too frequent or not frequent enough. This information is very good for the patients, and it does give a lot of good information. Remember, they don't have a drug guide at home to look up these medications, and we want to give reputable information to them. I encourage you at home, or maybe if you're walking in the pharmacy, if you've never really looked at medication labels before, I encourage you to read down through medication labels, kind of see what is put on these medication labels. It's just going to increase your learning a little bit. This does conclude the lecture on pharmacodynamics. I hope that you learned a little bit more about what the drugs are going to do to the body. And I look forward to seeing you soon. Hope you have a good day. Bye.